I'm Dr. Sarah Malowitz. I'm a clinical neuropsychologist here at Feiner. I've been here for 3.5 years, completed my postdoctoral residency here in the summer of 2009, and then got hired on full-time in February 2010 as a staff neuropsychologist. We evaluate each incoming client to get a baseline of their cognitive function. We administer a full neuropsychological battery, looking at different cognitive domains such as memory, attention, executive functions, language skills, and our findings we use to help improve the quality of our clients' treatment. We share those results with the skilled therapist to help them understand where they should focus their therapies on. We do an initial evaluation, and then as the client improves, we typically get another baseline evaluation. About 3 to 6 months in, some clients we evaluate yearly. And our pediatric clients we evaluate once, and then as they turn 18. Typically our clients, it's not uncommon for many of our clients to come in either with pre-morbid or pre-existing substance abuse issues, or as a result of the brain injury have actually incurred a substance abuse disorder. So it's very important to address this important facet of their treatment while they're here. And we do so in 2 primary ways. One, we administer a weekly psychoeducational group to educate the clients on how substance abuse actually impacts them after the brain injury. People who have sustained a brain injury are 3 times more likely to have another brain injury related to substance abuse. So it's very important that we educate them on the dangers of continuing to use after they've incurred a brain injury. The other way that we do is for people who have very severe issues. We actually administer individual psychotherapy, usually in a cognitive behavioral format, to help them identify really the driving forces behind their addiction and to help them process any kind of dysphoric emotions that are guiding the addiction as well, and also to really just provide more all-encompassing and more intense therapeutic interventions to help get that substance abuse under control. We also have very strong relationships with most of the 12 step groups here in Wauchula, and they go to several meetings a week. Now, I'm working with a client right now, and have been doing so for approximately 1 year, who comes from a different state, and they were struggling within that state's system of healthcare. Primary significant substance abuse, which would essentially induce them being discharged from placement. So they were hopping around from placement to placement, and they were not an appropriate candidate to be at the home because they were engaging in very aggressive behaviors toward family members. They came down here, we put them immediately into the substance abuse group. We screen during the evaluation for any significant issues related to substance use. And if a client appears to definitively require those services are immediately enacted. There's no waiting period at all. They've been doing individual psychotherapy for approximately 8 months, and they've been very participative in the substance abuse group, and they're now living in the duplex, which is essentially supervised independent living, and have completely abstained from any usage whatsoever, which is a really significant step for them. They've made gains that they were unable to make at any other facility that they'd been to previously. With substance abuse and brain injury, one of the reasons why it's so complicated is that oftentimes people do struggle with impulse control and quality of choice making. And those are subtle deficits left behind from likely frontal lobe injury. And those are the parts of the brain that we use to say whether or not a decision is a quality decision, and more importantly, what types of consequences will happen further down along the line. So if I were to think about, say, drinking alcohol, I would immediately think, I can't drink, it's Wednesday and I'm at work. And that is my frontal lobe saying, no, it's pretty severe consequences. When someone has incurred an injury to that area of the brain, they really struggle with thinking about the future consequences of their behavior, and they are more likely to engage in more immediate gratification. So what we have to help them do is relearn again, just as when they were a small child, relearn what a consequence is, understand that their use has been far more devastating to them than the feelings of withdrawing from the substance, and help them understand that their life is far more rewarding, and it's just a lot more fun. And when you're not struggling and you're not essentially a slave to this addiction. Each client that we get here, our main goal at the end of the day is to try to get them back to an independent level of living. And we help them understand that their independence is going to be very difficult to reach that level of independence when you are struggling with an addiction. And once they seem to comprehend that concept, they can make really substantial gains. And then, of course, we work with any lingering psychiatric issues which may have been aiding in it, such as bipolar disorder. We address those. We have a neuropsychiatrist here who addresses those with pharmaceutical interventions or pharmacological interventions. And we really help them see that at the end of the day, with work and with dedication, that you can have a very different life than you ever thought was possible. We're always working in a future direction. We're always working in a hopeful direction with our clients here, because we don't want anybody to, we want everybody to have the best quality of life that is possible for them. I drive in 75 miles one way each day, so I commute 150 miles, and I'm fully licensed by the state of Florida. I graduated from an APA accredited program. So I have a lot of choice when it comes to where I'd like to be employed, and I choose to drive that far to come here because I believe that much in the quality of the work that we do here.